Hey John, how are you?
Doing good. How are you, Dr. Wall?
Just Mr. Walt. Just actually, it's just Walt. No, don't have the doctor. Don't have the doctor. So, hey, we're getting together today to talk about a class that I've got scheduled for your clinic in Bismarck, North Dakota, on August 8th through 9th of this year. And you are a massage therapist who does a lot of myofascial release work, but yet, you were interested in having me come, who's I don't know what I don't want to say I'm anti-myofascial relief, but I certainly have moved on from, that blinder version of it's all about the fascia. Um,
Mhm.
can I just ask what sort of directed that invitation?
Yes, one of the things with your work, I started with a simple YouTube video, listening to you talk and share. One of the things that stood out would be what you call the shared decision-making, model or the shared decision-making process. And it really helped my myofascial release work. Um, Instead of just feeling with my hands and thinking of myself as the expert in this case and thinking that I know what the client needs, it helped me to engage with the client on a level that was so helpful. Just the simple question of, does this feel helpful to you? Does this feel safe? Um, it sounds so simple on the outset, but when I incorporated them in the decision-making process, the therapeutic decision-making process, it made a world of difference. It helped me to know, am I working on an area that feels relevant to them? Or am I working on an area that I think is relevant, but their body is not giving them cues that would inform them that it's helpful?
Yeah, yeah,
And wherever I'm working, whether it's at the low back, the calves, the arms, the neck, I found it just to be a universal principle. It's helped me so much in my myofascial release work, along with any deep tissue work, structural integration, this interaction with the client, and the ability to help them be part of that process.
yeah,
Uh, they found it to be helpful too. They have a
yeah.
voice.
Yeah. And I think that's you just summed it up right there. It gives them a voice in a situation, whether it's a massage environment, physical therapy environment, speech pathology environment, one where traditionally they're not, it's not that we forbid that from having a voice, having input, but I just don't see clinicians really, leveraging it, trying to get that input from them. Another question I ask now is, does this feel like a waste of time? It's sort of that neutral place. No, I feel safe, but it's not feeling like it's helpful. Okay, let's just make sure it's not a waste of time too. And I've got a lot of other words I use in there. Does this feel productive, right? Sometimes I have to just sort of bounce some words or phrases off of each individual patient until something really sticks and they understand what I'm asking. Have you had difficulty with patients saying, gee, things like, oh, do what you think is best?
Yeah,
Right? I
I've
mean,
heard that as
that's a
well.
yeah, yeah, it's so common. They hand power over to us, which is understandable. But in a lot of settings, it's like they've been sort of laughed at or made fun of for saying something to a health professional
Yeah.
that health professional found to be funny, or no, that's not how the body works. And I think a lot of people have learned just to shut up and not expose themselves to shame.
I found one thing that a lot of my clients say is that he listens. Part
Yeah.
of that starts with a question. I need to know their input to know, is this therapeutic? Are we going down the right road here? And sometimes they might wonder, well, you should know, John.
Yeah, you're an expert, don't you know? Right?
Right. But I know only what I know, and I don't know what they know. And
Yeah.
incorporating their experience and their felt sense in their body uh, gives me as a professional so much more understanding, leverage direction that I wouldn't have if I'm just depending upon my own understanding. I've literally worked on areas where I've asked them, does this feel helpful? I don't know. And in my mind, I think it's probably a no. I
Yeah.
work on another area and I press on that area and they'll right away, they know that's it. That's the
Yeah.
area or that's the spot.
Yeah.
And obviously, it's part of the picture. I don't just rely on their input, but that input is so critical in the whole scheme of decision making that I don't want to go without it.
Yeah. I don't ever want to underplay the value of, all the assessments, all the
Mhm.
experience we've had. But, I've been through a couple, multi-tiered lines of training, and that sense of sort of pushing you into a funnel of becoming an expert, that you're able to almost intuit or read another person's tissues or body, or, I don't want to just specifically name one, but there's a model that says that you're working with their inner physician, that somehow you can intuit what they're saying to you. It's like, why do that? Just ask them, right?
Absolutely.
Ask them. And I think that's a bit challenging from an ego perspective for experienced therapists and new therapists, right? Because it's like, no, I'm an expert here. You shouldn't be telling me what to do. And I'm like, no, I want you to tell me what to do. Or together we'll co-create what to do.
Yes.
Yeah.
That's shared process.
Yeah, yeah. So this is a Foundations in Manual Therapy Voice and Swallowing Disorders class, and it is the only class that I teach in a live format now. But you had talked about some of the massage therapists in the Bismarck area, had an interest because I have a myofascial release background, and I still work in what somebody could say, hey, he's doing MFR. I explain it differently. Does the explanation matter? I think it really does because the broader understanding of, well, it might not just be the fascia, but the neurological system, the behavior, all so many different things. I think it actually can help us have even better outcomes. But was it that shared decision making process that kind of drew you to ask me to come to teach this class?
That was a big part of it.
Yeah.
That and on a personal level, I'm planning to move into more teaching, but I found that the book that you published that I've read, phenomenal. The shared decision-making process and just your clarity of thought that I've followed even on the recent podcast with, I believe it was Whitney, the Thinking Practitioner podcast, recent to me at least. Uh,
It was very new. Yeah.
yeah, that's really drawn me to uh, I want to learn more. I want to have more proximity, but I also believe that the whole community, my local LMTs, myofascial release therapists, other PTs that I know in the area, I think we could all benefit. The shared decision-making model is a big part of that, but I
Yeah.
think we could all benefit and also just specialized work in the neck. I think some of us don't understand how many sensitive structures are present, or we don't have the confidence to work in that area. And I think some skill and precision and clarity of thought would be helpful.
Yeah. I really respect folks like Susan Salvo who really, kind of warn us against this area. And I understand her and I have spoken quite a few times about this, and I understand her reservations and concern from a medical and legal standpoint. Um, but yet a lot of us are working there on a daily basis. So what do you do? Do you just make it totally off limits and people have to go to the black market to learn how to do this stuff? It's like, as long as we have a good understanding of red flags, contraindications, medical history and background, huge ones, as well as now, this is something that I believe strongly. Shared decision making reduces risk because if somebody is, I call it biting on a stick while we treat them, thinking we know what we're doing, this hurts, but I hope it helps, right? If we take the stick out of their mouth and ask them what they're feeling, that's going to reduce real risk in terms of injury as well as the perception of risk, right? If they get
Yeah,
sore, right? No, no, he didn't ask me permission to do that. He just did it. So shared decision making, I think, is a route to improve safety. And yeah, there are dangers here, right? But there's dangers everywhere in the body. And, I have a very, a very I don't want to say protocol, but I have a system I go through to make sure that this person is safe from a medical history perspective, et cetera, et cetera. And if my patient is a stoic, bite on a stick person who refuses shared decision making, that's going to dictate where I'm going to treat and not treat because of that lack of cooperation from their standpoint.
that makes sense.
Yeah, yeah. And it's interesting too from a massage therapist perspective, or sometimes PTs or occupational therapists. It's like, well, sometimes without sounding rude, I'll say, well, why'd you come to this class, right? It's targeted for speech pathologists, not that that's the sole group, right? And some are literally saying, I've been following you on the internet and I want to learn more about this overall general approach. Or, you know what? I do a lot of work in this area and I want to feel like I'm more proficient. Or I get therapists who are actually working with performers or similar kind of models, and they want to know within their scope what they can do. But we also go into a lot of other, I think, really interesting areas, including, post-fibrotic change in terms of radiation induced fibrosis, how to work and how to deal with that, whether it's the face or the neck. We do a lot of oral motor. The tongue, The tongue used to, when I first started teaching this class in 2013, the tongue was, it was a little bit we did. Now it's what 25% of the class is tongue work and base of tongue work, not just tongue manual therapy, stretching, releasing, right? But we also have incorporated a lot of movement-based exercise, if you will, call it that, right? And I just find it fascinating when we start blending touch, manual therapy with movement, exercise, strengthening, call it that if you want, how that changes the entire environment so much.
It's-
Yeah,
For me, I've received some mouth work and it's been incredible.
yeah,
Both
yeah,
the speech, this list goes on. I found so much that's present in the mouth and the jaw, and
yeah.
been a game changer.
And I know a lot of I see on Facebook all the time people now looking for buccal massage. And I'm not quite sure what is driving that new sort of trend toward that, right? I
Yeah.
mean, I don't do what I consider buccal massage. I mean, we do a fair amount of work here in the oral region, whether it's, the cheeks or the lips, et cetera. But I'm also right now, you know, I feel like I'm still fighting that narrative from about a month ago when that Leanne Rimes video came out of Leanne Rimes being absolutely abused by a therapist with another person pinning her head so he could beat the living hell out of her pterygoids. And, okay, I get it. Some people were taught to treat that way. Some patients actually like that level of work, but for that to go viral internationally like that, with tons of people asking where they can get that work done, I think we've got a lot of catch up to do, John. I really do. Not that that's innately wrong. But I don't think that is the kind of model we should be putting out there for patients and for other clinicians to be emulating.
Definitely.
Yeah. So anyway, I've got a lot of things like that that really, push my buttons. I'm sure we all do. But is there anything else you want to say about the potential of this class or people who might be interested in taking it?
I'd be curious to hear from you for the speech therapists out there, those that are local in Bismarck. What's your typical kind of response from speech therapists after the class?
Yeah. I
Stood
think
out to them or what highlighted to them?
yeah, well, I think that's all over the board, right? Because
Oh,
I don't want to be universal in saying this, but for the most part, speech pathologists aren't taught manual therapy type interventions. If they are, it's a brief introduction to a concept called laryngeal manipulation, whether they heard about it in grad school or they saw it from a peer or somebody, colleague or something like that. And then often it's like, here, just go in and do this, and they'll go in and laryngeal manipulation has been shown to be very effective for voice disorders since 1993 when the first study came out. But it's also a very literal interpretation of the clinician as expert, where the clinician is taught how much force is necessary and then they go apply it. And I know I've had it from skilled clinicians and it feels pretty threatening to me. So I think what a lot of people, speech pathologists, who if they've been exposed to that, it's like I love the concept of allowing the patient to help you choose the level of force, the level of movement, how long you linger, instead of me saying, oh no, if we don't stay here for a certain length of time, lasting results aren't going to happen. And you and I are probably, really familiar with that statement. But I think what's really cool is when I look at studies and say, you know what? They only held that stretch for 30 seconds and it had a lasting positive impact, right? So it's some of those things. But I think, much like you just said in the early part of our little talk here, that it's that shared decision model, not just in manual therapy, but in everything we do, that sort of sets people free in terms of needing to be that expert, that all-knowing type of person. I never deny that I know a lot, I've experienced a lot, but my knowledge ends where yours begins. So let's co-create this together, right?
yeah,
And
that's
from speech pathologists, I certainly get a lot of other comments depending on their specialty area, right? Because that's as wide a range of field as any profession. And is this the miracle for every single patient? No, absolutely. But I think it blends well with just about everything we do. And I'm using the large collective we. In terms of the shared decision making model, that it really does add value to all of our interactions. I use it with my exercise patients. Does this exercise feel useful or do we need to modify it? Right?
yeah. What would you say to the massage therapists that do a lot of work in the neck, the shoulders, even the upper back? Is there much contribution as far as the anterior neck or significant contribution to their clients' relief, comfort, just in the upper torso.
Yeah, yeah. I can tell you that I first, so one of the techniques that we spend a fair amount of time is I've sort of renamed it to retrolaryngeal. We move in behind the larynx, between the larynx and the spine. I learned that as an anterior cervical technique in one of the advanced MFR classes. And, that was my bread and butter for decades in terms of getting into the space of the nerve roots, et cetera, et cetera. And that was exactly the technique that got me invited to teach my first class for speech pathologists because of the massive overlap. And I'm going back in history. Yeah, I use this work. I still use it today on my neck pain patients. Yeah, absolutely. I have a lot of other things that I do and you do with patients besides what's taught in this class. But a lot of this work, whether it's, in terms of the retrolaryngeal, the laryngeal region work, some of the work that, well, you probably learned this like I did at a thoracic outlet release. Remember that one, right? We made a lot of modifications and now we call it laryngeal anchoring for swallowing, for voice, for pain-related disorders, et cetera. So yeah, I mean, I obviously I'm looking through a biased lens here. I think there's a lot of value for the massage therapist, for the physical therapist, et cetera, not just the speech pathologist.
And the class itself is held over 2 days,
Yep.
and I believe pretty full days.
Yeah. Yep. And it's preceded by a 2-hour online course that basically sort of sets the tone for the underlying narrative of, the work that I do, both from an evidence-based perspective as well as a comparative manual therapy perspective. So, total of 16 hours, 14 hours of seat class time. So, spread out over 2 days. And it's some people, I'm going to be blunt with you. Some people find it a little slow moving because we do linger a lot on an area, on a technique. We linger a lot on the interview, the intake. Um, but I think that's key. Now, I know that in certain massage settings, your hour that you're paying for counts when your head hits the table, right? You're doing an hour work. And I understand that's for a lot of therapists, but other therapists are probably working more like I am, where, okay, you walk in, okay, when you walk into the door, your time starts. And intake to me is such a crucial part of that. That establishes context, that establishes fears, it establishes so many different things, right? And to me, that interview, that intake piece is crucial to transitioning to the table. Or in the case of this class, we teach a lot of it from a seated position. All right. So
Yes.
yeah, I think there's a lot of value around a lot of the things. And we only have, I think, 8 labs and throughout the entire thing, although each lab tends to have a lot of sort of sub techniques mixed in with it. But yeah, it's a fun class. I think it's fun. I've been teaching it now since 2013. And it's really interesting because I'm 64 years old right now, and I feel like I'm sorry, wait a minute, I'm 66. Where am I? Anyway, I kind of feel like with this, it really happened about 6 years ago where I decided to really shift my direction from teaching more whole body work for massage and fit PTs, et cetera, into this work, more of a niche type of market and model that I kind of really started fresh with a new career. And that's a really neat place to be at my age. So kind of neat.
That's excellent to be able to
Yeah,
reinvent yourself. And
yeah, yeah.
to
So
kind of close my comment, I think you hit it on the head with the intake piece is so valuable. Um, if we don't know the right target that we're looking to achieve or focus on, we can spend the hour focusing on something that's not as related as we think it is.
yeah,
Uh, or
yeah,
if the client doesn't feel safe or heard, if they're not able to relax on the table, what can you do with their nervous system if they're not as present with you as they could be, as
yeah,
on, and it's
yeah,
so critical to be on the same page.
yeah, exactly. All right, John, thanks for your time. And I look forward to seeing you in August. And hopefully some of the viewers here decide to take that leap and join us. All right, John, thanks for taking the time to talk with me today. And if anybody has any questions, you can contact me directly from my website, which is waltfritz.com. And I'll see you in August, John.
Sounds good. Thank you, Walt.
Okay, you're welcome. All right.